Our next speaker is Dr. Hind Salama. She's a consultant adult hematology at King Abdulaziz Medical City, Riyadh. She's an assistant professor at King Saud bin Abdulaziz University. She has a special interest in ALL and histiocytic disease. She initiated the first adult histiocytic clinic in the region. We're proud of you, Hind. So, floor is yours, please.
Assalamu alaikum. Thank you, the SSBMT, for inviting me, and thank you, Dr. Amal, for this introduction. And let's warm the conference room a little bit. So I'm going to, my session today will be two parts. The first part is a brief about HLH, and the second part is IEC-HS, which is HLH-Like syndrome secondary to CAR-T. So what's HLH? HLH is a severe syndrome of hyperinflammation driven by massive overexpression of interferon gamma, result in blood cells engulfing other blood cells, like what you see here in the smear. So to understand the mechanism of HLH, you need to know the normal immune system. So in the picture, in the slide here, on your left side, this is the immune system. So when a body is exposed to a trigger, for example, a virus, your immune system will activate the CD8 T cell, and it will release interleukins and cytokines and interferon gamma, and then there will be a negative feedback in red to terminate this immune system and get rid of the organism. But if you have a defective in the enzymes that encode for the cytotoxic T cell, like deficiency in perforin, like in primary HLH and other enzymes, then this negative feedback will not occur, and there will be a hyperstimulation, a storm, increased interferon gamma, activation of macrophage, engulfment of the cells, and this is the whole pathogenesis of HLH. So what are the causes of HLH? We have primary HLH and we have secondary HLH. So primary HLH is mainly because of immune deficiency syndromes or defect in those, or mutations that lead to defect in cytotoxic T cell, as listed here. But I'm an adult physician, so primary is not our main concern. We see it rarely. So our main concern is in adult is the secondary HLH. And the most common cause of secondary HLH in adult is malignancy HLH, and mainly lymphomas, and mainly T-cell lymphoma and NK cell lymphoma. So in adult, whenever an older patient presents with HLH, we need to search meticulously for an underlying malignancy. The second cause is infection. Any infection can cause HLH, but the most common is the EBV, the CMV, and any other infection. So, and there is an HLH secondary to autoimmune disease, and this is referred to as MAS, macrophage activating syndrome, but it's the same as HLH, and management is the same. And now recently, people started to recognize a new syndrome, immune effector cell, HLH-like, which is secondary to CAR-T cell. And if you did not find the cause, this is idiopathic HLH. So we as adults, we get many consultations. Come and see this patient. We think this is HLH, ferritin is high. But we know that in adults, it's not like in children. Ferritin can be high for many other inflammatory or other reasons. So we cannot accept any consultation as HLH just because the ferritin is high. So most of the experts use the 3 F terms. The first F is the falling count, means unexplained cytopenia, and persistent fever without a positive culture or a real cause. And the last one is high serum ferritin. So if you found these 3 together, then think of HLH, and you need to apply your scoring system to diagnose HLH. So this is the HLH 2004 diagnostic criteria, and I'm sure most of us are aware of. It's either a primary disease or one of the genetic defects that we mentioned, or 5 out of 8 of these criteria. But in 2024, Hinter and his colleague, Hinter is the one who created the HLH-94 protocol and the HLH 2004. He recognized that HLH 2004 works with an accuracy of 99% without the NK cell function. Most of us, we don't do the NK function, but still we diagnose HLH. So they removed the NK cell function from the HLH 2004, and they name it HLH 2024, where you need only 5 out of 7 criteria. But if you look at the ferritin here in this diagnostic criteria, they use a cutoff of more than 500. 500 is not applicable for us in adult. It's not an indicator of an underlying HLH because we have 500 for many other reasons. Even if the patient has a fever for a flu or anything, it could be 500. So this HLH 2024 or 2004 is suitable for children with primary HLH. It's not applicable for adult patients with secondary HLH. So the French group came with the H score, which is a score that took into consideration the ferritin level. So if you have a ferritin, for example, of less than 2,000, it was given a 0 mark. So you need a ferritin of 2,000 or more to consider HLH or to consider it positive mark. So they give grades to each parameter. They consider also the underlying immunosuppressive. They gave it also marks. And then this is an easy calculator available online. Then they will, you have the probability if the scoring system is 169 or above, this is positive score. And if it is 250 or more, then you have a 99% probability of having HLH. The beauty about that is all the parameters here are usually available when you see the patient, and the calculator is ready online. You can use it and calculate. And then you can sign off of the case or in. Recently, there is a context-specific HLH scoring system. So this is Lorenz Zorev came with this scoring system for lymphoma patients. So when she looked at the HLH 2004 diagnostic criteria, she found that for a lymphoma patient, the only 2 sensitive criteria are the soluble CD25 and the ferritin. So if you have a normal soluble CD25, which is interleukin-2 receptor, and a normal ferritin, then, and the patient had HLH, then very, very unlikely that this patient will have an underlying lymphoma. But if the soluble CD25 is more than 3,900 and the ferritin is more than 1,000, this is a positive OHI index, and it's highly suggestive of underlying lymphoma. Not only that, it also correlates with the survival of the patient with lymphoma. So patients with positive OHI index, they do worse than the other patients. So whatever scoring system you use, and also there is a context-specific scoring system for mass used by rheumatology. Whatever scoring system you use, the most important thing is to diagnose your patient quickly, because here time means money or life. So for the management of HLH, I usually say 2 steps. 2 steps go together head by head. So the first step, keep your patient alive. Please, till you know the underlying cause, and treat your patient. Keep your patient alive means suppress the cytokine, suppress the inflammation, so the patient will not end into multi-organ failure, and then you lose the time. So how to keep him alive? Most of us are concerned about steroid, will mask my lymphoma, will mask my sepsis. Don't worry about that. The most important is to keep your patient alive. Unless if you have a biochemical markers of HLH and the patient is stable, then you can search for the lymphoma and do the diagnosis. But keep him alive using steroids. Don't be afraid of steroid. Use anakinra. Sorry. Use anakinra. Anakinra does not mask the underlying lymphoma. It's available everywhere. It's cheap. It does not worsen the sepsis. Also, if you have the facility to have imapilumab and patient did not respond to first line, don't hesitate to use it to suppress the inflammation. While you are doing the first step, you do the second step. Search meticulously for the underlying cause, okay? So do all the investigations, and of course it will be obvious if the patient is post-CAR T, you don't need to do much of work. Now, how to manage the patient, to manage the underlying cause, the HLH-94, everybody is aware about it. But again, this one was mainly for pediatric patients with primary HLH. Adult patients do not tolerate these large doses of etoposide twice per week and prolonged steroid. If you have to use it, and when you use it if you have a severe inflammation and you don't have an access to, that does not improve with steroid and with anakinra, and you don't have an access to imapilumab, for example, or you are suspecting an underlying malignancy or in EBV, HLH, because usually it's severe, then you can use it, but you use lower dose, 50 to 100 milligram, once per week instead of twice per week, so some modification. Now, ipilimumab is a humanized monoclonal antibody, FDA approved for primary HLH and for macrophage activating syndrome last year. And real-world data showed some benefit in malignancy-associated HLH and in other secondary causes. What are other medications? Anakinra, I talked about it already. It's an anti-interleukin-1 receptor, frequently used in mass, but can be used in any HLH, secondary HLH. Ruxolitinib recently started to be used also because of the role of STAT activation in HLH. Alemtuzumab only in refractory cases and in conditioning chemo for transplant. Tocilizumab has very limited role in HLH beyond the CRS secondary to CAR-Ts and bispecific. Zanubrutinib, this is in ASH 2024. This is very interesting because this is an oral medication, and here they check zanubrutinib in patients with secondary HLH. The majority of them were macrophage activating syndrome. And 50% of the patient had achieved remission, and this is very interesting because those are relapsed refractory. We usually lose those patients, and there is normalization of the cytokines in those patients also. This is a promising medication. This is a trial from MD Anderson, the ELA-026. The importance of this is that it had signal regulatory protein alpha and beta 1 and gamma, so it blocks several signal regulatory proteins, not only one. And they tried this medication in malignancy-associated HLH, and they reported 100% response rate and improvement in 2 months survival, but this is only 2 months, and I didn't see any follow-up data about this medication, maybe next ASH. So my conclusion from this part is that over the last decade, our understanding of HLH biology and management have advanced considerably. If the patient has the 3 F's criteria, apply the proper scoring system to diagnose HLH. Bone marrow is not diagnostic of HLH. So the presence of bone marrow biopsy with hemophagocytosis or no hemophagocytosis, this is just one parameter in the scoring system. It's not diagnostic, it's not exclusive. Once diagnosed, a 2-step management strategy should be applied instantly, and HLH-94 does not fit all patients, so you should modify your treatment based on the underlying cause, and it's time to use more effective and less toxic agents. So the second part of the talk is, since this is an EBMT meeting, is about immune effector cell-associated hemophagocytosis like syndrome, IEC-HS. So this is Melissa Hines. She's a pediatric intensivist who is interested in HLH. So together with her colleague from the American Society of Stem Cell Transplant and Cellular Therapy, they published this nice guidelines about diagnosis and management of IEC-HS in 2023, actually. So they defined the IEC-HS as manifestations with features of mass or HLH attributed to immune effector cell therapy associated with progression or new onset of cytopenia, high ferritin, coagulopathy, and or transaminitis, and how to differentiate it, delay in onset and manifestation as CRS is resolved or resolving. So in the next slide, we'll see, so the conditions required, again, hyperferritinemia, and Melissa used 2 or more times upper limit of normal. And many adult HLH physicians criticize this because, again, she's a pediatrician, so the 2 or more of upper limit of normal is nothing for adult. So most of the adult HLH experts use 7,500 or more to make it like a sensitive marker of IEC-HS. And then the other important issue is the timing of onset. So usually it's after the resolution of the CRS, because it mimics CRS, so we need to differentiate between CRS and IEC-HS. So it's usually after the resolution of CRS, and you can have transaminitis, new worsening cytopenias, hypofibrinogenemia, also bone marrow hemophagocytosis, although not necessarily to do a bone marrow, and other manifestations like high LDH, coagulopathy, and organ failure. Also, the timing differs, depend on the type of CAR-T you are using. So if you are using the CD19 CAR-T, it could occur simultaneously with the CRS, and this will be confusing, but it's how, when you are giving treatment for the CRS, and then the patient initially improving, and then he lost the improvement, then think of IEC-HS as a cause, change your management to the management directed towards IEC-HS rather than TOSI for CRS. But for the BCMA CAR-Ts and the CD22 CAR-Ts, usually after the resolution completely of CRS, 2 or 4 weeks, then it will occur. So it's easy to differentiate. So there is a grading system. I will not go through that. You will find it in their published articles. The grading varies from 1 asymptomatic to 5 deaths. What's the incidence of IEC-HS? Actually, the incidence varies in many reports because some of the reporters reported only severe cases and some reported mild cases. This is in Hind's publication. She put this incident from real world, but also the incident varies based on the type of CAR-T. For the CD22 CAR-T and the BCMA CAR-T, they can reach up to 30%, and for the CD19, it's up to 3% or 6% in the maximum. People look also at the outcome of IEC-HS based on disease. So for example, those are children with B-cell ALL, and they look at patients who develop IEC-HS post-CAR-T and patients who did not develop. So as you see, the overall survival and relapse-free survival are worse in patients who develop IEC-HS, mainly because of the non-relapse mortality. Also, this is a real-world data looking at BCMA CARs following ide-cel and cilta-cel in patients who develop IEC-HS. And this is a multi-center trial from all through USA. They look at progression-free survival based on the development of IEC-HS. And they found that patients who receive ide-cel or cilta-cel, if they develop IEC-HS in the dotted graph, they have worse outcome regarding the progression-free survival and overall survival than patients who did not develop IEC-HS. And they found also in this publication that the predisposing factors for developing this complication are high baseline ferritin. So if the patient from the start has high ferritin, this is a risk for IEC-HS. If the patient is pentarefractory, myeloma pentarefractory, and if the patient has high plasma cell burden in bone marrow. This is nice, and we need to look at this in other disease subcategories other than myeloma. Now, why some people develop IEC-HS and some people do not? We know that high ferritin, high disease burden, these are indicators, but is there any other factors? So this is a study from Boston. They look at patients in the ZOMA-1 trial. They look at 110 patients actually, and they look at those who develop IEC-HS, and they look at this expression of STAT2, and they found that patients who had IEC-HS had high upregulation of STAT2, while patients who did not develop the, I will say HLH-HS, they did not have any STAT upregulation. Moreover, there is more upregulation of interferon gamma, interferon alpha in those patients. So baseline high interferon gamma and high STAT2 will make those patients at risk of developing IEC-HS. We know this is primary HLH, and there are many genes encoded. So is there any genetic role of genetic mutation in IEC-HS? So there are two studies. The first study, both of them were presented in ASH, one in ASH 2022 and one in ASH 2025. So the first study, they look at 5 out of 9 patients who develop IEC-HS, and they found that they, post-CD22 CAR-T, they found that they have STXBP2, and we know that this is a very important gene in primary HLH. And a group from MD Anderson also looked at 11 patients with IEC-HS after CD19 CAR-T, and they identified 9 genes, including UNC13D and STXBP2. That means even if the patient does not have primary HLH as a cause of bone marrow transplant, the patients who develop IEC-HS, some of them have this genetic predisposition to HLH. So this will raise a question whether we need to screen those patients before CAR-T or no for primary HLH. So now for the treatment. For the treatment, Heinz, she recommended for the first line to start anakinra first, and if the patient did not improve, to add steroid. For the second line, to increase the dose of anakinra and add cortisone, if not yet added, and consider ruxolitinib. For the third line, if all this did not work, she recommended to add ipilimumab. And each line, when you move from each line to other line, you need to, again, search for the other etiology. But this How I Treat article was published just last March in 2026. It's more informative, actually, and more detailed than the Melissa's guidelines. Here in grade 1, they advise not to give anything, just observe the patient, and there was a debate whether to observe the patient outpatient or inpatient, but the majority chose inpatient because patient can rapidly, from grade 1, go to grade 2. In grade 2, they advise to give anakinra first, and they put the doses for anakinra, and steroids if anakinra did not work, and you can add, and generally it's not added ruxo and ipilimumab, not for grade 2, but for grade 3 and 4, optimize the doses of the anakinra and steroid, add ipilimumab, different dose for grade 3 than grade 4, and add etoposide if you do not have ipilimumab and ruxolitinib in your center. So I think for every center that will do CAR-T, we need to have ruxolitinib and ipilimumab available in-house if you are doing CAR-T in case you develop this complication, especially if you are doing the BCMA CAR-T, which has a 30% risk of IEC-HS. For the monitoring, this was based on expert opinion. This is a monitoring, and I think most of us will do this monitor, except we don't test for the CXCL9 because unfortunately we don't have it in Saudi Arabia. However, there are efforts now to get this test done. And the nice thing about, in the same article of How I Treat, I advise every person who deal with CAR-T to go and read this article. They put a taper strategy. For us in HLH management, we seldomly see taper strategy. We don't know when to stop, whether to stop suddenly, whether to taper, but most of them, they advise to taper gradually, okay? So the first thing to taper is steroids and anakinra. Once the patient improves, after 7 days, start tapering it, and they put how to reduce it every 24 to 48 hours. Prioritize
5 minutes.
Yeah, this is my last slide. Prioritize weaning steroids before anakinra, especially in patients with poorly controlled diabetes or older patients who are at risk of hospital-acquired delirium. However, if the patient had previous ICANS, steroid and anakinra should be tapered very gradually. Ruxolitinib, taper it more gradually. Start once organ function improve and reduce by 2.5 to 5 milligram every 24 hours. They did not talk about the taper of ipilimumab, I think because still the experience is developing. They don't know when exactly. So my conclusion from this part, Heinz's recommendation, they were very excellent, but they have some limitations. First, it was based on expert opinion. Second, despite she put the cutoff, the time as still you cannot differentiate between CRS and IEC-HS except by timing, especially in the CD19 CAR-T, which is overlap. So we need more definition maybe in the future. Each CAR-T center should create their own management guidelines based on the available facilities. So if you have, if you don't have ipilimumab, ruxolitinib, you need to put etoposide if you could not control it, if you have it like that. So each center should develop their own management guidelines. Consider testing patients for germline mutation associated with primary HLH before CAR-T, because as you see, many of the patients who developed this complication had germline mutation. Monitor closely patients with baseline high ferritin and high burden disease, because also those who are at risk. For severe cases, use ipilimumab and ruxolitinib as suggested in the two published articles. And do we need prophylaxis for those who had high disease burden and those with high ferritin? This is a question to be answered in the future. And with that, I conclude. Thank you so much.
Thank you so much for comprehensive review. Any question? Dr. Hind, Can I ask you, how can we differentiate HLH occur with CAR-T from CRS, and how do you manage this?
This was mentioned in the last part of, in the second part of my talk. You differentiate actually by the criteria, definition criteria that is put high ferritin, they put certain level, and they put the timing. So the timing is the most important thing to differentiate. So usually it occurs after the resolution of CRS, many weeks, or overlapping when you improve, when the CRS improve with TOSI, and then the patient lose the response suddenly, you need to look for IEC-HS. And high LDH and other features, they put it.
Okay, thank you. So now we are moving into the next speaker.